Well, Lauren, thank you so much for joining us and being willing to talk a little bit on camera. Can I
Pleasure.
actually ask you to introduce yourself and
Sure.
tell us a little bit about your professional background?
Yeah. So my name's Lauren Cadish. I live in Los Angeles, California. I'm a urogynecologist, so I'm a physician who did a residency in obstetrics and gynecology and then a fellowship in gynecologic surgery with a focus on pelvic floor disorders. And I finished my fellowship training in 2015 and started work at Providence St. John's Health Center in Santa Monica, which is where I've been for the past 8 years. And 4 years into my attendinghood, I made the decision in 2019 to look at programs to get a master's in healthcare quality. And I've been doing the program at a decelerated pace. So over the course of the maximum time, which is 4 years. And so I'm getting set to graduate this year in spring of 2023.
Well, it sounds like you're doing the rest of the course of your life is at an accelerated pace. So, there's some complementarity there. Why did you start exploring graduate programs anyway at this point in your career?
Yeah. So I've always had an interest in healthcare quality. It was a big deal at the institution where I did my residency. And so that's where I was first exposed. And I think that there was always an awareness that whenever we're doing our specific job, that we are an important cog in a much larger machine. And that awareness sort of only grows with time as you get sort of a higher and higher view of the medical system. I also think that, at least for physicians, our lives are very much divided into 3 to 4 year increments. And certainly during our training, every year sort of feels like a promotion. Being a third year medical student is a much bigger deal than being a second year medical student. Being a second year resident is a way bigger deal than being a first year resident. You really feel like you are learning at a very good clip. And that also gives the impression that when you finally emerge, you are at some pinnacle, which in some sense is true. It is a very long road. But, by the time I finished my fellowship, I was 34. A lot of my same aged peers were already considered mid-career, and I was just at the beginning. But by the time I was 4 years into that, I was getting a little restless. And I love clinical medicine. I love surgery. And it is very gratifying to be able to fix something and to be able to see the person whom you have helped. But you are very much dependent on the system around you. And so I wanted to get more into the weeds of that system and feeling like I might be able to make an impact faster than one patient at a time.
I like this idea that as you got higher and higher in level, sort of looking down, the little cogs got smaller and smaller. But what attracted you to the program at Johns Hopkins? You might have considered some other programs too.
So in the end, the program at Hopkins was the only program to which I applied. I started in a very, very non-scholarly way. I typed master's healthcare quality into a Google search and looked at what my options were. I really believe that my mentors in quality and a lot of the people who are bigwigs doing quality work now, that cohort really had only on-the-job training, because we date the healthcare quality movement to approximately 1999. And so for a long time, there wasn't really anybody who had formal education in this. But I think that, like all things in medicine, there is a tend toward specialization and formal training. And for my cohort, I really think that having formal training in healthcare quality is, if not yet, going to soon become a prerequisite. So, even though all of the programs are relatively new, I think when I matriculated with a cohort that would have been the third graduating class. Hopkins had the Armstrong Institute, which had been it, and its precursor had been doing quality work in a formal way for a very long time. And so I really felt that you had the background and the faculty. I liked that it was a partnership between the Armstrong Institute, the School for Public Health, the medical school, and that there was a little bit of that multidisciplinary thinking that went into designing the program.
Well, we'd like to think so, but I'm glad that it struck you that way too. Now, having just about completed the program, what would you tell people who are considering applying?
Yeah. So as an applicant, I was very concerned about the live talks and the need to be present at specific dates and times. I'm in a 3-hour time difference with Baltimore, which pales in comparison to some of my classmates who are from all over the world. But I was worried about that. I was worried about it conflicting with my clinical schedule and with my familial responsibilities. I started the program the year that my second child was born. So hence the reason I've been doing it at a slow pace. So I was very concerned about whether I'd be able to show up and be present at the times required. And that really hasn't been an impediment whatsoever. Everything has been recorded and easily accessible. And I've been able to, it's always nice when you're able to be present, engage in the conversation in real time, but that really hasn't detracted from my ability to partake fully in the program. So I think that was an unnecessary concern. And I've been overall really pleased with it. I'm excited to graduate, but in a way, I'm kind of sad to see it go. I think a lot of us are lifelong learners, and so having something scholarly where we can still be students is just a fun thing where you're not giving the same spiel to another patient again and again. So I'm a bit sad to see it go.
Well, we have fun with it, so I'm glad to hear that you do too. It should be, you can't convey all knowledge even at a decelerated pace over a few years. But as long as you're excited about it, engaged and interested, I guess it does go pretty quickly. What skills or tools do you feel like you've gained through the program?
So one skill that I had been sort of trying to acquire for a long time prior to the program, I had taken a number of statistics classes from college to residency to fellowship. And so I had a decent background. I had worked with biostatisticians on some of my own research. And so I had some background there, but I had never been able to feel comfortable really in the weeds stats wise. And so Professor McGreedy's classes were among my favorites. And I thought that having seen a lot of people try to teach stats and seeing it taught sort of at a too rudimentary level and at too high of a level, I was very impressed to see him sort of hit the bullseye and make it, at least to those of us who are proud nerds, really fun. The other skill that really sticks with me is this idea of doing a pre-mortem, which I think is a salient term. So the idea when you're at the beginning of an initiative, to sort of think and say, okay, if we get to the end of this and it's been a colossal failure, where do we think it was that the train came off the tracks? And I find that to be a very useful tool when one is in the trenches and thinking about how to design something, because inevitably things don't go according to plan, and being able to put yourself in the shoes of imagining where things could go wrong, I think goes a long way to prevent failures in our initiatives for improvement.
I can see how both of those things are useful. I will say that Johns Hopkins prides itself on being able to teach biostats so that people understand it and like it.
Yeah.
Are there any examples of how you're now using some of this information, some of this newly acquired information or skill?
Yeah. I was working at my health center in preparation for one of our Joint Commission visits about trying to reduce the frequency of therapeutic duplicates. So patients who have, say, more than one narcotic prescription, and that's something that the Joint Commission can certainly give you a citation for. And so that required me to work with the quality leadership, some of the ICU physicians and nurses, and some of the technology people, and then some of the pharmacy people, and trying to communicate with all the different stakeholders and figure out how we were going to address that. And so that was my my most recent way of putting my skills into practice. And we didn't get any citations on our Joint Commission visit related to therapeutic duplicates. So I felt like that was at least a short-term success. And then, you know, the fly is always in the ointment about how we can maintain our success over time, but having a proof of concept is really, I think, quite meaningful.
So thanks for all your examples and for being willing to appear on camera here. Do you have any sort of last words, suggestions?
Not that I can think of. It's been a really positive experience, and I really hope that they don't cut off my Welsh library access, because I've been using it so much. I want to make sure that I keep my Course Plus and my Welsh library access after I graduate to help me with my research, and because I plan on referring back to a lot of my coursework going forward. So if you can make that happen, that would be great.
Well, you should also keep in touch with your classmates and with your professors. We are very interested in seeing how you succeed and seeing how you use some of the tools that we try to impart.
Yeah,
and
Julia Kim was my advisor, and she was really helpful. I spoke to her midway through about how to arrange my courses, and she really said, okay, this is the order that we want to plan this out in. And that was very helpful to make sure that I still had that attachment to a faculty member, even though I've never met her face to face.
Well, you'll get a chance to meet her at graduation. But regardless of that, keep in touch. We're very interested in keeping in touch with you. You're part of now part of a network, and Hopkins is a good place to be from.
I agree.
Thank you again.
Thank you so much. I appreciate it.
Good luck in the OR.
Thank you. Bye-bye.